Many of you will know us. We've been working together managing patients for the last few years, and for those of us who don't know us, I'm Nick Contarinas. I work at Royal Perth Hospital and also at St John's in Subiaco. So welcome tonight. We thought we'd cover a broad range of gastroenterological topics, starting off with Dr Sam Rao, who's going to talk to us about gastroesophageal reflux and H. pylori. Sam has done his training here in Perth at both Charles Gardner Hospital and Royal Perth Hospital. He's then gone off to Canada to do his fellowship in interventional endoscopy. He's a very gifted and talented endoscopist, so we give him all our difficult cases, the very large polyps, ERCP, endoscopic ultrasound. But tonight he's going to talk to us a bit about a common GP problem, reflux and management of Helicobacter pylori.
Thanks a lot, Nick.
Thank you.
I believe I need to project my voice, so if you can't hear me out at the back, please let me know. My break into song is what it feels like, but if you can't hear me, please put your hands up and I'll try and be a little bit louder. Thanks for the lovely introduction, Nick. It's a fairly small group, nice tight group, so let's not make this didactic. I'm very happy to be stopped at any point and ask questions along the way if you want to. But I thought I'll talk about something relatively common that no doubt all of us have seen in our practice. I'd like to give you a little bit of an update on gastroesophageal reflux, and we'll use that as a segue to talk a little bit about Barrett's esophagus and then Helicobacter pylori. So I'll outline a case and then we'll jump right into it. So here's a case, quite typical of what we would probably see or you would probably see in your office. A 55-year-old male. He's got hypertension, he's got a background history of type 2 diabetes, it's fairly well controlled, but he's obese, he's got a BMI of about 32, and he sees you in the office for about 4 weeks of heartburn and acid reflux. He's got 4 years of similar symptoms, albeit fairly intermittently, and he's not really done much about it, which is pretty much a classical scenario with most of these patients when they come and see us. So quite rightly so, you diagnose him with gastroesophageal reflux disease. But what really is the burden of this? It's fairly common. It's the leading diagnoses of all GI disorders, certainly in the US. This data is from the US. And it involves about 20% of the adult population. And 1 in 4 gastroscopies performed in the US were for investigation of symptoms for reflux. And of course, the management of this with PPIs does put a burden on patients. This is, of course, the US data. This is not Australian, and aren't we lucky to be here? $2,000 a year for PPIs in the US. So it primarily is a disorder of the esophagus. So we do know that there's increased acid exposure to the distal esophagus or the bottom end of the esophagus. So the patients do present with symptoms that are classical of reflux. These include heartburn, as well as acid regurgitation and some degree of water brash. But patients tend to be fairly vague. A lot of them do walk in, and I'm sure you've noticed that a lot of them walk in and say, I've just got some indigestion. So it's quite important to tease out what their symptoms actually mean. Is it actually reflux, or could it be dyspeptic symptoms, wherein really they present with belching, bloating, maybe some degree of epigastric pain, as well as passing a lot of flatus. So no doubt there's a significant overlap with underlying irritable bowel disease. Often these patients do have clear precipitants for their symptoms, be it whether it's chocolate or hot and spicy food, fatty meals, or even red wine, as most of us are drinking tonight. These symptoms do respond very well to antacids as well as PPIs, but we'll talk a bit more about that as slides to come. That's not very well understood, unfortunately. We don't really know how acid reflux actually develops and what the underlying pathophysiology of it really is. But what we do know is that the distal esophagus is exposed to a lot of acid from the stomach. So stomach is full of acid, and that tends to reflux up into the distal esophagus. In general, this is prevented by the high tonicity of the lower esophageal sphincter. So at its resting state itself, the pressure at the lower esophagus can be as high as 30 millimeters of mercury. And generally, you need only about 5 to 10 millimeters of pressure to prevent that reflux. So that lower esophageal sphincter usually only opens antegrade when food's coming down from the esophagus, or even opens when there's retrograde movement, when you're vomiting or even belching. Now, this tension at the lower esophageal sphincter is further reinforced by the passage of the esophagus right at the gastroesophageal junction at the level of the diaphragm. So it's easy to see when you do have a hiatus hernia, when the proximal end of the stomach slips up towards the thorax, that this sort of level of pressure maintained by the diaphragm is disrupted, and it exposes the distal esophagus to acid fairly easily. So hiatus hernia associated reflux is seen in about 50 to 90% of the patients. Saliva is fairly important as well in the prevention of reflux. Saliva does help neutralize acid that gets exposed to the esophagus. So this is why we see smokers presenting with a lot of reflux symptoms, because they just don't make as much saliva. So coming back to our lovely patient, so quite appropriately, he's been advised to lose weight. He's been told to avoid fatty meals. And as expected, he gets a script of pantoprazole at 40 milligrams daily. Certainly this makes most of the patients happy. But immediately the next question he asks you is, do I need any investigations? But really the answer is there's no specific investigation that's warranted to clinch the diagnoses. Response to therapy is a very good indicator of acidification of the distal esophagus. So trial of therapy is probably our best approach, not just to treatment, but also to confirm the diagnoses. Endoscopy, which is often performed for further investigation of reflux, is often normal in about 50% of the individuals. So we don't see any features of ulcers or erosions, the so-called entity of non-erosive reflux disease. Barium swallows are quite helpful to demonstrate the barium that's refluxing up from the stomach into the esophagus, but this is just a single snapshot. It doesn't really tell us as to what's been happening across a period of even a day, for example. It is useful to demonstrate complications from reflux, however, such as strictures or even, of course, cancer. pH study I'll talk a little bit more about on the next slide, but manometry or measurement of the esophageal pressures is quite important, particularly when repair of hiatal hernias are being considered. So this is how pH studies are actually performed. So there's a pH-sensitive probe that's passed through the nostril all the way into the distal esophagus. It's maintained about 5 centimeters proximal to the gastroesophageal junction. And this probe can measure when the pH in the distal esophagus is less than 4, and you can record that. The probe is attached to a little monitor that the patient carries with them, and they document when they're having their symptoms and what posture of their body habitus is leading to these symptoms. Once these recordings are performed for a period of about 24 hours, it spits out a score that you can then review and tabulate. So it comes up with something called as a symptom index, which is calculated basically by dividing the total number of symptoms wherein the distal esophageal acid exposure, the pH is less than 4, divided by the total number of symptoms. And if half the symptoms, or more than 50% of the symptoms, do have episodes wherein the pH is less than 4, it's thought to be a positive result. So endoscopy should be considered particularly when there are any complications that could arise from reflux. We all know about the so-called alarm symptoms, so these patients should be referred across for endoscopy to investigate for symptoms of dysphagia or dinophagia, weight loss, vomiting, iron deficiency, anemia. Sometimes the older patients presenting with new onset symptoms, or even older patients with long-term symptoms, should be referred across, primarily to ensure that there's been no complications from long-term acid exposure to the distal esophagus. I would also recommend that patients have an endoscopy when there's poor response to PPI therapy in about 4 to 6 weeks, particularly if they're on twice daily PPI. This is again to make sure that we're not missing a diagnosis, or of course, are we potentially dealing with a complication of gastroesophageal reflux. So this is what we see in endoscopy, keeping in mind that about 50% of the time the endoscopy can be completely normal. What we do see when patients do have erosions or ulcers can be fairly varied. It can be as mild as a small tiny little erosion at the gastroesophageal junction, or something as severe as ulcers involving half the circumference of the esophagus, or even the entire circumference of the esophagus. This, of course, can lead to healing by scar tissue fibrosis and eventually lead to fibrosis and stricture formation at the distal esophagus. This also predisposes the patients to developing Barrett's esophagus and subsequently, of course, esophageal adenocarcinoma. But our lovely patient is back. He says, the pills are not working, doc. And he asks you if he needs any more treatment. And this is how I explain it to our patients, or most of my patients, that really it's a two-pronged approach. It's not just a physician-directed treatment for reflux, but the patients do need to take some onus onto their care as well. Weight loss in particular has been shown to be very beneficial for improvement of reflux symptoms. Smaller meals consumed more frequently are often beneficial. Staying upright after meals for about 2 to 3 hours, just using gravity to your advantage, does seem to benefit patients and their symptoms. Avoiding precipitants, obviously, such as smoking or alcohol, hot and spicy food, or even fatty foods. But even self-medicating with PRN medications such as an antacid, if and when they do get breakthrough symptoms, is what the patients can do. But what we can do is, of course, reinforce all these measures, the lifestyle measures. And what we do have is some medications to reduce the amount of acid in the stomach, keeping in mind that our therapy can't really affect the pressure at the lower esophageal sphincter. So what we do is really just reduce the amount of acid that's already there in the stomach. Occasionally, surgery is required for repair of hiatus hernias, and at the same time, the surgeons can often perform fundoplications, which I'll talk about in a minute, to help with patient symptoms. So the treatment really is directed by what the magnitude of symptoms actually are. So medical therapy, as I said, cannot alter the lower esophageal sphincter function. So all our focus is on reducing the amount of acid that's already there. So antacids do help neutralize gastric acid, and they're fairly quick acting, but they are of a shorter duration. And 80% of the patients with milder ulceration often require lifelong intermittent PPIs, and this is almost 100% when they have more severe ulceration. So for example, on the previous slide when I showed you the bottom 2 slides when they had severe ulceration, nearly 100% of those patients do require intermittent lifelong PPIs. So these are what we have in our back pockets, what we can prescribe to our patients. So the old player was the H2 blockers, which can still be used as an adjunct to PPI. But the reason it's used as an adjunct is because only 50% of the patients do report some degree of symptom benefit. They do have rapid onset of action, and just a quick note over here on ranitidine. Most of you will probably know that it's off the market because of a carcinogen. And NDMA, it's some methylamine compound that has a low risk of causing low risk of carcinogenesis, but therefore it's been pulled from the market. There are, of course, other H2 blockers available. So PPIs, which are really the cornerstone of management of gastroesophageal reflux. And the reason they are the cornerstone is because about 80% of the patients do report symptom relief. And when patients have nasty ulcers on endoscopy, 90% of those ulcers do improve with PPI therapy with follow-up endoscopy. They do have a slower onset of action, of course, and keep in mind that there are streamlined authority codes now from the PBS for use of PPI, and the codes are 8774. Sorry, go on.
Sam, is the ranitidine carcinogenic or is it a contaminant that's carcinogenic?
It's a contaminant. Okay, it's in the...
It's not carcinogenic.
Correct. The question was whether ranitidine itself is carcinogenic or whether it's a compound in the medication itself. So it's not ranitidine, the active compound, but there is a so-called NMDA within the drug itself which can potentially lead to carcinogenesis. So that's why it's been pulled. Prokinetics seem to be an attractive option, but unfortunately there's no proven benefit for use of prokinetics such as domperidone or even metoclopramide to try and help with the sort of propulsion of the acid from the distal esophagus back down into the stomach. That's a shame. It does look like a viable option, but it just doesn't work.
Is this applied to all the other H2B or only?
Only to ranitidine. Yep. So what we often find is patients represent and say, oh, look, the medications aren't really working. And the minute this happens, we've really got a query as to whether this patient definitely does have gastroesophageal reflux, or whether it could be an alternative diagnosis, whether this could be cardiac, whether this could be an ulcer that's leading to dyspepsia, whether this could be incorrect use of the medication, wherein they're taking the medication after their meals really when the production of acid has already sort of happened even with the first morsel of food in your mouth. So the PPI should really be taken about 30 to 40 minutes before meals to try and stem the production of acid, otherwise the horse is already bolted. If PPIs aren't working, twice daily PPIs might be required for a shorter duration, but sometimes it might truly be an underlying condition of hypersecretion of gastric acid, the so-called Zollinger-Ellison syndrome, which is a completely different beast. But often what we find is a lot of these patients have true esophageal hypersensitivity of hyperalgesia, and these patients respond well to low-dose tricyclic antidepressants, similar to the doses that we would use in irritable bowel syndrome, for example. So just a quick slide on the fundoplication procedure, so very useful, particularly when there is a hiatus hernia. So the surgeons pull the stomach back down below the diaphragm, and using the cardia and the fundus of the stomach create a wrap around the distal esophagus. So basically they've created an artificial tightening around the distal end of the esophagus to increase the pressure at the gastroesophageal junction to prevent reflux of acid from the stomach up into the distal esophagus. Acid reflux can be annoying. I'm sure all your patients have noted that it not just leads to complications, but it can also affect the quality of life. It affects their social life. Patients often have a lot of chronic cough. Caries and halitosis, or very bad breath, can also develop from reflux. But concerningly, it can lead to stricture formation and subsequently dysphasias, but it can also lead to Barrett's esophagus. And of course, Barrett's esophagus can lead on to development of esophageal adenocarcinoma. And lately, in the last 5 years or so, there's been a lot of concerns about long-term acid suppression as well. This is an example of a stricture at the distal esophagus. So a lot of acid exposure to the distal esophagus, which in turn leads to a lot of ulceration. That heals by scar and fibrosis and stricture formation, and that's seen on the fluoroscopy here. These do lend themselves to endoscopic management, so they can be dilated with various different devices and often respond very well. But the other more drastic complication of gastroesophageal reflux is Barrett's esophagus. And this is really a metaplastic transformation of the squamous epithelium at the distal esophagus to columnar epithelium, which is pre-malignant but goes through a variety of stages before it can develop cancer. It goes from a lower grade of dysplasia. Nick?
Question on Barrett's. Would you recommend somebody who presents with reflux for the first time that they do have an endoscopy just to rule out Barrett's?
It really
if they respond to the PPI, is it worth just having a one-off check?
I think it depends. It largely depends if they're male. So Barrett's esophagus is very uncommon in women. It also, but I'd be more so keen for patients to have an endoscopy when they're middle-aged, men, overweight, definitely if there's a family history of esophageal adenocarcinoma. So a younger individual, first-time presentation, clear precipitants in terms of food, good response to PPI, I probably wouldn't. But if they've had symptoms for at least for a duration of 5 years, then I certainly would make sure that they've had an endoscopy. So it does progress through anywhere from low grade, high grade, and then to cancer. And the risk factors are long-term reflux symptoms, male gender, or a family history. And how we manage this is with maximum acid suppression along with low-dose aspirin, which has been shown to be beneficial in regressing or even slowing progression of dysplasia. But the good thing about Barrett's is it lends itself to surveillance when it's low-grade dysplasia. So these patients generally have an endoscopy at least at the minimum of every 3 years for biopsies to make sure that there's no progression of the dysplasia. But even high-grade dysplasia and even early cancer does lend itself to treatment. So high-grade dysplasia can be ablated, so we can burn it off at the distal esophagus using a few fancy catheters and different ablation devices. But early cancer can be resected, so if it's restricted to the mucosa and not to the deeper layers of the submucosa, this can be endoscopically cured, as I can show you on this example here. So this is a middle-aged gentleman, actually sent across by Nick, who had high-grade dysplasia and a very short segment of Barrett's. And given it was a very short segment, I proceeded on into resecting it endoscopically. So this is a little device that gets attached to the end of the endoscope. And these little wires here help us deploy these rubber bands around the abnormal mucosa. And then using a snare, we can just lasso that off. And that's the resected area at the bottom end that you can see there. So that's actually the submucosa of the esophagus. So this gentleman actually had early cancer, which was restricted to the mucosa, and in essence, he's had a cure. But of course, this does require surveillance.
Excuse me. Like why I feel that acid suppression is not related to changing the prognosis of parasitic. Is this right?
No, that's not true at all. Okay, even patients with early dysplasia require maximal acid suppression. Otherwise, what we do know is does progress on. The question was about the need for PPIs even when patients have low-grade dysplasia, or whether PPIs are definitely required to prevent progression of low-grade Barrett's dysplasia to a higher grade or even cancer.
Can you expand on the role of aspirin in this situation as well? I know that you had one of the management options with Barrett's.
Can I what on aspirin, sorry?
On aspirin, I'm not familiar with aspirin, whether it was in the management of Barrett's.
So it's pretty new evidence, really. So the question, sorry, I've got to keep that in mind. The question is about the use of aspirin, because it's not particularly common that most of you will probably seen that patients with Barrett's are on aspirin. But it's pretty new evidence. In the last about 48 months or so, there's been quite impressive studies which have demonstrated impressive results with low-dose aspirin, 100 milligrams of aspirin. So certainly most of us who do manage these dysplastic Barrett's, our patients are often on aspirin and maximal acid therapy. So no doubt you'll see more and more of your patients with Barrett's esophagus on aspirin.
Would you advise stopping alcohol for people with Barrett's, saying it's one of the main...
I don't think there's enough evidence to say that you... Sorry. The question is as to whether if you have Barrett's esophagus, whether you can continue drinking your wine. And I think the answer really is that you've got to limit alcohol intake to a safe level. Okay? There is no clear correlate between Barrett's esophagus and the amount of exposure to alcohol that is required for you to develop esophageal adenocarcinoma. So unfortunately, we have nothing to suggest that you can have one drink or even 3 drinks and you will be safe. But what I would recommend is that they have safe limits of alcohol consumption and definitely alcohol-free days. Okay.
Is still the same advice for someone with reflux, but is managing his symptoms with just lifestyle changes? Does he require to be on acid suppressant medication? And if it should be like DRN, lowest dose? And is there any difference between DBI and the H2 blocker regarding some evidence of relation to chronic kidney disease?
Sure. The question really is about whether patients who've got low-grade symptoms of acid reflux, as to whether they would require long-term PPI or H2 blockers, particularly if they're doing well with lifetime modification. And the answer really to that is no. I mean, unless they're a middle-aged person, middle-aged male in particular, and they've got a long history of acid exposure and recurrent symptoms, if they don't have Barrett's esophagus, if they're controlling their symptoms purely with lifestyle measures, I'd continue recommending that they continue with their lifestyle modifications. PPIs and H2 blockers, particularly if they're taking it on a PRN basis, I think it's absolutely safe. Okay, most of us do prescribe PPIs fairly easily, really. I mean, there are some concerns about it, but as long as they're being monitored, I've only ever had one patient who's developed acute kidney injury from the use of a PPI. So I think it's absolutely safe, particularly if they're taking it on a PRN basis. Oh, and to answer your question about H2 or PPI, I'd go PPI because we know it works better for their symptom control. It does take a little bit longer to work, though. It can take about 2 weeks for the maximum benefit. So if it's just a one-off symptom, they can even use an antacid, such as Gaviscon or other such, and a H2 blocker is probably fine too. So, sorry, go on.
It seems to be relatively common to get a little bit of microscopic bleeding, so they drop their iron and sometimes hemoglobin. They're also on these NOACs, and they might be on, say, maximal PPI.
Yes.
What do you sort of do to balance?
This is from Barrett's esophagus, is it, or from?
Plus, they have to be on Xarelto or Eliquis or something for their history of CVA or atrial fibrillation or something.
I think the very first instance in that is making sure that there's no ulcers or erosions at the distal esophagus.
Sometimes there's microscopic ones that,
I'd go twice daily PPI for sure, and if they, I've got to repeat the question again. Sorry, the question is about patients with reflux disease who are on one of these NOACs, and they have intermittent sort of low volume bleeding and potentially some iron deficiency. And I think the best situation in that is to go with maximal acid suppression. Sometimes you can add on a H2 blocker, but really what's important in that situation is making sure that there's no endoscopic erosions or ulcers that are persistent, especially to make sure that these are not transformed and these are not dysplastic ulcers. All right, so back to our patient Homer. He has an endoscopy. He's got no changes or erosive changes of reflux. He does have a small hiatus hernia, but he has a rapid urease test at the time of his procedure, or a CLO test, and this comes back positive, so we'll use this as a segue to sort of jump into Helicobacter. I'll move on a little bit faster now just for the sake of time, but I'll jump right down into the indications for diagnosing and treating Helicobacter. And what's established is patients who have complications from Helicobacter, such as ulcers, cancers, or even lymphoma, they certainly should be investigated and treated for Helicobacter. But there are some acceptable indications where patients can be investigated for Helicobacter, such as dyspepsia, use of a concomitant NSAIDs when their risk of developing ulcers do go up by about 6-fold. If there's a strong family history of gastric cancer, or sometimes even unexplained iron deficiency, although this is controversial. I'll probably skip over the slide on investigations, but there are non-endoscopic and endoscopic investigations, so I'll skip over what we do at the time of a procedure. But most of us, what we would probably do is a serology or a rapid or a urea breath test for diagnoses of Helicobacter. The good thing with serology is that it's easily available, it's inexpensive, they have a very good negative predictive value, but they're very poor positive predictive value, particularly if you've come from a low prevalence community, and they're not useful to monitor response to treatment, unlike the urea breath test, which again is hampered by the fact that you can't have the test done for a number of weeks after you've had antibiotic therapy, or for at least a week or two once you've stopped the PPI therapies, when they can have a urea breath test. But it's essentially what we have to check for cure after treatment. Just in terms of treatment of Helicobacter pylori, the cornerstone really for now is amoxicillin-based therapies. Amoxicillin, along with clarithromycin or the Nexium HB7, has about an 80 to 90% efficacy in terms of eradicating Helicobacter. Amoxicillin resistance itself is rare, unlike clarithromycin resistance or even resistance to flagell. Flagell in particular can be a nuisance, where resistance can be as high as 50%. Clarithromycin is as up as at about 10%. There are some reports of extending the period of amoxicillin and clarithromycin-based therapies from 7 to about 14 days, which increases the clearance rate from anywhere from 70 to 85%, keeping in mind that the previous slide I said that amoxicillin, clarithromycin, the efficacy is about nearly 90%. For penicillin allergies, the combination therapy is flagell and clarithromycin for a period of 7 days, and this is about 80% efficacious. But really, often what we get involved with is the true second line for true failures. So I would progress on into levofloxacin-based therapies for salvage for eradication. So this is a combination with levofloxacin and amoxicillin, along with the PPI for a period of 10 days. And this in general has upwards of an 85 to 90% eradication rate. Keeping in mind, though, that levofloxacin does require a special access scheme form to be filled out. You can do this through the TGA website. You can do it online. You often get a response very quickly. But the biggest nuisance with levofloxacin, which I'm sure some of you have come across, is that most pharmacies don't stock it or are a little bit reluctant to dispense it, purely because it's a bit of a headache for them. They've got to contact a supplier, then procure it, and then dispense it to the one patient. So I don't think it's very beneficial for them. But there are a few pharmacies, particularly compounding pharmacies, who will dispense levofloxacin. Sometimes I've even had to get levofloxacin dispensed across from a very helpful pharmacy from Sydney. Yes?
So just with the poor positive value of the serology,
Yes.
is it better to go through the process of getting the breast test, or just straight on the serology?
The question again, I'll repeat it, is about whether we should be using a serological test for confirmation of diagnoses, given that it has a poor positive predictive value, or whether we can go directly on into a urea breath test. And I think that really depends on the situation. It depends on the individual that you're managing. So if they've come from a high-risk community or a high-risk country, their prevalence could be as high as 70%, as opposed to our prevalence here, which is about 20%. So it might not be particularly useful if you're doing it for an individual who's born and raised here without a lot of risk. In that individual, a urea breath test might be more sensitive. But if an individual has come with classic dyspeptic symptoms from a high-risk community, a positive serological test I would treat. Particularly, for instance, if they've got ulcers in their stomach or duodenum. Sorry, one more.
What are high-risk communities?
So a lot of the African countries and Asian countries. Predominantly all of them.
How long after the treatment would we do the post-urease test? And also, how many times before we give up?
So how many weeks after treatment should the urea breath test be performed? And the answer to that is at least 4 weeks. If you can even push it up to about 6 weeks. They've got to be off the antibiotics for a minimum of 4 weeks, and at least 1 week off the PPI. And sorry, I forgot the second part of the question.
How many times before we give up?
Right. Okay. And that's really here. So this is what we often find. The second part of the question is how many times should we try before we can give up? And often what happens is that patients get a retrial of amoxicillin and clarithromycin or Nexium HB7, and that response rate is only about 10%. Okay, so really if they've had a true proper go at Nexium HB7, if they've been compliant with their medications, they've had no background exposure to clarithromycin or even flagyl, and they don't respond to the Nexium HB7, I would be referring them across because they immediately jump on into a levofloxacin-based therapy. Just a last slide on some take-home messages. Look, reflux is common. The reports would suggest about 20% of the adult population do suffer from this. Heartburn and acid regurgitation are the primary complaints of these patients. Anything else, you've really got a question as to whether this is reflux or whether this is dyspepsia from an ulcer or something else, even like biliary colic. The differentials we've also got to keep in mind, particularly for the middle-aged males, is whether this is cardiac in nature. Sometimes esophageal hyperalgesia or hypersensitivity could be the underlying issue. A trial of PPI for about 6 to 8 weeks is completely acceptable. I would taper the PPI slowly over 2 to 4 weeks rather than a sudden stop, because this can lead to a rebound, increased production of acid, which can worsen symptoms. Endoscopy and pH testing might be required, particularly at the at-risk population. Complications such as strictures, Barrett's esophagus, and cancer need to be monitored and can be surveyed endoscopically. And in terms of Helicobacter, they respond well to triple therapy. Most of your patients should be responding, about 80 to 90% of them. There's a poor response, only about 10% to a re-challenge with amoxicillin and clarithromycin, and I really would progress on into a levofloxacin-based therapy if they've had a proper go at Nexium HB7. And with that, I'll end there.
Yes.
Sorry, when you say taper over 2 to 4 weeks, do you mean going half and then second daily, third daily? What's the taper?
So it really depends. Everyone has their own regimen, really, and nothing's really the question. Okay, I'll remind you next. Yes, the question is about how do we actually taper PPIs, and really there are a variety of regimens out there. And what I would do, for example, is I'd go down from a 40 down to a 20. And I'd get them to take the 20 milligrams every second day, every third day, and then go on to a PRN as and when required, rather than suddenly going from 40 milligrams to nothing the next day.
That's because
it's not an exact science. So
it's not an exact science,
so
yes. It's like the reduction in dose of prednisolone, for example.
Yes. Yes.
Testing household of the patient.
So definitely for the questions about testing household contacts for Helicobacter, and again it depends on the community and depends on what the risks are. If they're from an at-risk community, so if they're a migrant from Africa and Asia even, it's not unreasonable to test, especially so if not just that they have symptoms, but more so if there's a family history of gastric adenocarcinoma.
One final question. Does sometimes treatment of Helicobacter can cause worsening of reflux symptoms?
The question is about whether treating Helicobacter can lead to worsening of reflux symptoms. In actuality, reflux and Helicobacter pylori are not really related. It's Helicobacter pylori doesn't actually lead to reflux. It do cause a lot of dyspepsia. So realistically, it shouldn't.
Shouldn't.
Shouldn't,
Ah,
yes.
yeah.
How do you
Yes.
label someone as Zollinger-Ellison syndrome?
How do you treat it?
How do you label someone?
Look, it's very, very uncommon, thankfully. I mean, amongst the four of us here, I'm not sure how many we've seen. I should repeat the question. The question is about how do you investigate, treat Zollinger-Ellison syndrome? And I was just elaborating that this is quite a rare phenomenon. It's not a common neuroendocrine tumor where you can produce a lot of gastrin, which can lead to Zollinger-Ellison. I was just putting the question out there to my colleagues if they've actually seen one, because I haven't seen one.
I've perhaps seen one.
Perhaps seen one.
I've seen one.
So
Yeah. It's a combination of high-dose proton pump inhibitor, but usually there's an underlying cancer, or the tumor, the neuroendocrine tumor. So they require specific oncological therapies, such as things like long-acting octreotide, like sandostatin, and then often, depending on how aggressive the cancer is, they may require more systemic chemotherapy.
Yeah.
So we tend to involve our oncology colleagues, or if it's a single lesion, it can be resected. It's usually multiple small lesions.
So they do present with quite extensive ulceration in the stomach as well as duodenum. Zollinger-Ellison syndrome patients also can present with diarrhea just because of the amount of acid. And as Nick said, really this is a sort of malignant or a pre-malignant syndrome, so it's a neuroendocrine tumor which functions and then produces out a lot of gastrin, which increases acid production, and that can cause the ulcers. So depending on where the focus of the neuroendocrine tumor is, often the first step is surgery, but depends, completely depends.
All right, and I think we'll go to the last question now. Yes.
It's unrelated to a lot of what you've talked about, but if we get somebody with a really clear, severe sports injury,
Yes,
and you ask them, can you take Nurofen, and they say, oh, it gives me a bit of indigestion,
yes.
would you be happy to prescribe, let's say, celecoxib and a PPI?
100%.
Yeah. Okay.
100%.
When do you start getting nervous about doing that?
Well, I think our views are a little bit skewed because most of our on-calls are because of non-steroidal anti-inflammatories.
Yeah.
So for example, I'd be surprised if
Yeah.
any of us here in the room take PPIs for anything more than a day. But in
Yeah.
general, if it's going beyond about 48 to 72 hours, concomitant cover with PPI is not unreasonable. Particularly if they've got underlying Helicobacter, because the risk of ulcers can be about 6 times higher.
And how long would you say to the patient, like just for the first how many days, take this and this together?
For the duration of their PPI requirement, and hopefully, or rather the NSAID requirement.
Okay, so if that's a week, that would be
Yeah.
okay? Yep.
That's completely fine.
Okay.
Unless they've got dyspeptic symptoms after, and then wherein in that situation it's not unreasonable to continue for a further 2 weeks.
Okay.
Okay. Yeah, one last
Quick one.
question.
Yeah, sorry. So just with screening colonoscopies at age 50, is there any added benefit in getting a gastroscopy?
So the question is about patients who are being referred across for a screening colonoscopy as to whether they should also be referred across for a screening gastroscopy. And in general, there's no clear evidence as to whether you should be looking at the esophagus or even the stomach for suspicious lesions. It's not unreasonable, of course, if they have symptoms, and definitely not unreasonable if they are from particular ethnic communities such as Koreans or even Japanese who have a very high risk of gastric cancer. So those individuals do actually get surveyed with an endoscopy every year. So if those patients are being referred across, it's definitely not unreasonable. But for a fit and well 50-year-old, born and raised here, completely well, it's a little bit hard to justify a screening gastroscopy.
Good, okay.
All right,
I think
thank you
we'll
very much.
wrap up. There's a lot of interest there. I'll call Cannon to the lectern. We'll go straight to the next presentation. But while we're getting ready, I'd also like to mention our practice manager here, Natasha.